So welcome everyone. We are very pleased to start today's end of month lectures of the Hadassah Medical Center in Jerusalem. And we have two topics for today. We're going to speak a little bit about pediatric ophthalmology in the first half. And then Professor Shahar Frenkel will lead us into ocular oncology. And we have some very interesting and amazing guest lectures. And I will start by introducing the first guest lecturer, which is Professor Wilson. Let's see if I can do this. Do you see my screen? Okay. So this is for you, Ed Wilson. This is the way Hadassah looked before we actually added some extra. Now we have some people who are not able to enter. Shahar, look around if you can see someone who is not able to enter, because I think we have some. Okay, so let me introduce you to the first lecturer today, Professor Edward Wilson. He's going to speak about pediatric cataract surgery and the pearls and pitfalls. Professor Wilson, he is a professor of ophthalmology and pediatrics at the Storm Eye Institute at the Medical University of South Carolina. He has done his residency in ophthalmology at the National Naval, I have to move you around, Medical Center in Bethesda, Maryland. He did a fellowship in pediatric ophthalmology under Marshall Parks in Washington, D.C. And then, since then, he is now a professor of ophthalmology at the Storm Eye Institute. He was the director of the residency program in the 90s, and he was also, and is also the Pediatric Ophthalmology Fellowship Program Director. And during the years 96 until 2011, he was the director of the Storm Eye Institute and the chairman of the ophthalmology department. Edward Wilson is on the APOS board of directors. He has been the past president of APOS. He was also the president of the American Ophthalmological Society. He sits on the editorial board of the Journal of APOS. He is the executive editor of American Journal of Ophthalmology. He has won several awards, among them the Senior Honor Award from the American Academy of Ophthalmology and the Lifetime Achievement Award from APOS. And you all know him from the infant aphakia treatment study. Edward Wilson has done a lot of research, and he has focused mainly on pediatric cataracts and also strabismus in children and adults. He is a well-known speaker, and he has given more than 700 presentations and many named lectures and published many books. This one is from my own library of the pediatric cataract surgery. It's an excellent book for all levels of those who are interested in pediatric cataracts. He has published more than 200 scientific papers, chapters, and invited editorials. Ed Wilson, the doctor, well, this is how we know him. He has actually been selected by his peers as one of the best doctors in America. And he was the top 1% in the US, America's top doctors list. So this is quite impressive because there are quite a few doctors in America. And for everyone who knows him, he's really a worldwide authority on pediatric cataracts. And here we see him examining one of his young patients. Ed Wilson is also a great teacher, and here you see him on two occasions on the left during a surgery trip with his fellows to Guatemala, and on the right surrounded by fellows and staff at the APOS, one of the APOS meetings. Ed Wilson is, of course, also a family man, and I remember once I tried to convince him to come to Israel long before the corona to give us a lecture, and he said, no, I am unable to come because I want to stay at home with my son. And here we see him on the left. and on the right with his wife, Donna. But for us, Ed Wilson is really the greatest inspiration in pediatric cataract. We all cite his works, we all look at what he does, we all ask him questions. He's a great person to just write an email when you have a tricky case, and he will humbly and wisely advise us on anything in pediatric cataract. What I didn't know is this picture is that he's actually an amazing photographer. And here you see one of them when he's out trying to catch animals in the wild on his camera. So we are all extremely lucky and honored to have Ed Wilson with us tonight, and that he will share with us the pros and pitfalls of pediatric cataract. So I thank you very much for coming and participating. I will try to do this. Shahar, can you see and hear me?
I can do both.
Okay, good. That's very important. If you can do, then everyone can. So we have actually asked Ed to, I should probably take this one down, I don't know. We have actually asked Ed to give us his talk by this presentation that he recorded for us. But Ed is with us all the time, and he will have a lot of time for questions after the lecture. So I advise everyone who has a question to please put it up on the chat, and we will look through the questions and present them to Ed so that he will be able to answer them after this talk.
Well, good evening, and I can't thank you enough for inviting me. I wish I could be there in person, and maybe in the not too distant future, travel will be again safe. In the meantime, I know these virtual meetings are the best we can do, and so I hope you enjoy this information, and I hope we have plenty of time for question and answer. My title is Pediatric Cataract Surgery, Pearls and Pitfalls, and we'll try to see if we can cover some material that's interesting to you. Now, the first thing to reiterate, I know that you know this, but cataract surgery in children is very different than adults. Genetic and metabolic conditions often coexist with childhood cataracts. The cataract may just be a marker for a systemic condition, so we're always on the lookout for that. Microphthalmia often coexists with congenital cataracts, and the microphthalmia may be severe, and that implies a developmental abnormality of the entire eye, and certainly of the anterior segment. In those eyes with microphthalmia and microcornea, secondary glaucoma is common, and we found that the glaucoma can occur months to many years, even more than a decade after the cataract surgery. In addition, pediatric cataracts are thought of, at least by us, as a pan-ocular condition many times. Here's an illustration. This is a case where unexpectedly there was a hypoplasia of the fovea. This child had an unexpectedly poor result after cataract surgery. That was it was a developmental cataract, and you can see that the pediatric cataracts may involve not just the lens, but the entire eye. And during the ages when we're operating, there's a lot going on. The visual acuity is not yet mature. You don't get a mature macula to get 20/20 vision until around 48 months. Axial length is growing rapidly at first, and it continues its growth throughout the growing years. Keratometry is flattening in the early months. The lens power changes. It reduces to offset the axial growth, and that gives you a relatively stable refraction during the growing years. As you know, the risk of amblyopia is high early in life, so deprivation from delayed surgery can be devastating even when you do a perfect surgery. And not all pediatric cataracts are alike. We spend a lot of time describing what lens layer is involved, and whether there's microcornea or microphthalmia, because the cataract type can be a critical determinant of outcome. It can tell us whether the cataract was likely congenital or not, and it tells us about the risk of secondary complications like glaucoma. Now, this is an age distribution of cataracts, consecutive cases of cataracts in my practice, and you can see that I have grouped them into three. They're color-coded. This first group operated in the early months of life, and then this second group, which goes from the latter part of the first year all the way through maybe age 6 or 7, and then the age 8 until maturity as a third group. And these groups will often require a different surgical approach. Now, in that first group, the early infant, you notice that was a pretty high spike there. I see a lot of those cases. The infant aphakia treatment study, as you're probably aware of, recommended that an intraocular lens not be placed in the age 0 to 7 months. The outcomes were not worse with an intraocular lens, but reoperations were much more frequent. On the top here is an ophthalmic technology assessment from the American Academy of Ophthalmology. And in this document, they recommend that, if possible, that eyes in early infancy be left aphakic, and that an intraocular lens be placed later in life rather than primarily. And in the article in the center of the page, we put together the effects of the infant aphakia treatment study, and I think my practice and many others, we see much fewer intraocular lenses being implanted in those early months. This child pictured has a microphthalmic right eye with a contact lens in place. In data recently published from the Pediatric Eye Disease Investigator Group, PEDIG, their registry shows, these are unilateral cataracts, that intraocular lenses tend to be implanted primarily after the first birthday. Bilateral cases, same thing, very few intraocular lenses implanted until after the first birthday. And then most children received a primary intraocular lens. Now, for me, this is my preferred surgical approach in these small infants. I like bimanual surgery. I use a 25 gauge vitrector, and I use an irrigating cannula. And what you can see is I've done a primary vitrectorexis using the cutting port. Then I've aspirated the lens with the cutter turned off, but using the instrument as an aspirator. And then I turn the cutter back on, and I removed the posterior capsule. This had a posterior capsule plaque. I matched the anterior and posterior capsular openings. This is very quick and atraumatic surgery. One time in, one time out, no OVD, ophthalmic viscosurgical device needed. This is the child on the first postoperative day. What I do is I place the contact lens on the eye at the end of the surgery. No need for a patch and shield, and the child can start using the eye right away. And you can see this approach leads to very little inflammation. If you implant in early infancy, the intraocular lens implantation process in a small eye creates a lot more inflammation. Now, another reason, if you have access to contact lenses and aphakic glasses, another reason to withhold implants in these early infants is here you can see the result of the rapid eye growth. In in these patients of mine, the median contact lens power went from a 32 down to the mid-teens just by 36 months. So, and then it starts to flatten out, but you have this rapid change, which is hard to predict if you are deciding on an implant power. Now, I put this slide up because aphakic glasses are still used. And for bilateral cases, especially those that have difficulty acquiring contact lenses or keeping them in, we use aphakic glasses. I view these as a placeholder to get the child to an age where growth has slowed down, the eye is larger, and we can better predict the intraocular lens power to place. And so that's how I look at aphakic glasses. Now, there are going to be children where a contact lens isn't appropriate, especially a unilateral case. You can't use aphakic glasses very easily in a unilateral case. So here's a technique I want you to consider. This is a 4-month-old, and what I've done is used the same bimanual technique as I showed a minute ago to do the vitrectorexis, lens aspiration, and then I will do a posterior capsulorhexis just like before. The difference here is, and a shallow anterior vitrectomy. The difference is I'm going to place a lens in the sulcus, in the ciliary sulcus, rather than in the capsular bag. The reason for doing that in this select group, in these young children, is because the high rate of reproliferation causing visual axis opacification, the reoperation rate, is because of placing the lens in the capsular bag. The capsule seals to itself better than it seals to the acrylic lens. And so when new cortex is made, it fluffs out into the visual axis. However, if you place a lens in the sulcus and then you capture the optic through both the anterior and posterior capsule, this is bicapsular capture, you allow the bag to seal, and that reduces the visual axis opacification. And I find those lenses are easier to exchange. Now, in this baby, I used a new device. This is Dextenza. It is an insert that releases dexamethasone in a programmed taper over a 4-week period. Placed in the lacrimal puncta, it will now release dexamethasone. And this child ended up not needing any drops at all. No additional drops were needed other than this insert. and antibiotics, I used intracameral antibiotics, so I didn't use any drops at all. Even if you do use some drops, the Dextenza is one way to avoid the problems with parental compliance, where the parent can't get the drops in. All right, now, if I've left the child aphakic in early infancy, my most common time to put in a secondary implant is in the preschool years. I like to do this at age 4 or 5. Here I put age 3 to 6. Most of the time, I can place the lens, the secondary lens, in the capsular bag rather than the ciliary sulcus. Not that there's anything wrong with the ciliary sulcus, but what happens in these children is the capsular bag seals, the active lens epithelial cells continue to create new lens cortex. No matter how well you clean the cortex, there are a few epithelial equatorial cells remaining. And those cells create new cortex, and that fills up a sommering ring. It's useful in our situation because it maintains the space. Now, what I've done is I made a small opening using the MVR blade just above the fused anterior and posterior capsule. Now I'm using the vitrector. I turn the vitrector with the cutter on, turned the cutter to the side, and I've created a new capsular opening 360 degrees. Then I turn the cutter off and I aspirate the material within that sommering ring. Then what I'm left with is the capsular bag. The white ring is the posterior capsule opening, and you'll see, it's a little hard to see on the video, but you can see that there is a new anterior capsular opening that I've made that is round and intact, usually. Now I'm placing viscoelastic, OVD, to balloon up the capsular bag. Now, this allows me, you can see, I think, the edge of the capsule. It goes all the way around the new anterior capsule. This allows me to use a secondary IOL that is a capsular bag IOL. So I'm able to use a single piece acrylic lens, one that I would not place in the ciliary sulcus. So this lens is going to remain in place for 70 plus years, and if possible, I would rather have it in the capsular bag, and this technique allows that to occur. So you can see the lens is delivered, and then it will be carefully placed within that reopened capsular bag. The ease of this second surgery depends on how careful you are in the first surgery in leaving an appropriate amount of capsule and leaving a matched anterior and posterior capsule opening. Now, this is an article that I think you really should be introduced to. This is one of 3 articles we've now written under the subtitle of the toddler aphakia and pseudophakia study. What we did was all of the infant aphakia treatment study surgeons, we gathered data on patients from 7 to 24 months. So the infant aphakia treatment study, for those who don't know, was from 0 to 7 months, and it randomized children to aphakia with a contact lens versus a primary implant. And we have now reported on 10-year data. We've reported on 1 year, 5-year, and 10-year data. But we all have seen that surgeons begin to generalize the results of the infant aphakia treatment study to children that are older than 7 months, and that should not be done. In this study, we found that the outcomes from 7 to 24 months, this article is on unilateral cataracts. We've also written on bilateral cataracts in this age group. What we see is that above 7 months, it is much more recommendable to place an intraocular lens primarily. We find that the incidence of reoperations from visual axis opacification drops dramatically after 7 months. And the incidence of glaucoma, secondary glaucoma after cataract surgery, drops dramatically after 7 months. And this is very important. And so we need to recognize that the 0 to 7 month group is different than this 7 to 24 month group and of course older kids. Now, what I like to do in this group, this second group, if you remember my color-coded chart at the beginning, in this second group, I like to do a manual capsulorhexis, lens aspiration, bimanual IA, and then place the lens in the capsular bag. And for me, I like taking the posterior capsule and doing an anterior vitrectomy through the pars plana. And that may seem daunting to some, but I find that I have much more control using this, this method. And I've done this through the pars plana more than 1,000 times. It's very safe. The advantages here are that I have removed all of the viscoelastic before I open the posterior capsule. And so it reduces or eliminates the idea of having a vitreous wick come forward to the wound. So I leave the irrigation anterior and I enter the pars plana for the posterior capsule opening in this group. And the long term is great. I mean, there's very few that have a visual axis opacification. You do get some pearls on the edge of the rhexis, but they very seldom will cross and enter into the visual axis. And of course, I've removed a bit of anterior vitreous in these young children as well. Now, as you can see already from the videos I've shown, I use the vitrector a lot. And in pediatric cataract surgery, we're so accustomed to dealing with the vitreous that these cases, which we see a lot, this is a spontaneously ruptured posterior lentiglobus. What I'm showing here is the fishtail sign. If you can see the cortex fishtailing in the back, that's an indicator that there is lens vitreous admixture. We detected the rupture of the posterior capsule with our ultrasound prior to surgery. And then you can see I'm doing the entire case with a vitrector so that when I get to this ruptured part of the lens, then I can just turn the cutter on and remove it. Now, once I clean this up, the lens and vitreous that has mixed, I can see the spontaneous posterior capsule rupture opening. It has a little fibrosis on the edge, so I tend not to enlarge it. I tend to leave it alone. I try to make sure that I have a very good anterior capsule opening in case that's all that I have. In this case, and in many, we are able to use the capsular bag. So this American football shaped posterior capsule opening was left alone, and I was able to then just place the lens within the capsular bag and not have to rely on the ciliary sulcus. Now, I want to mention one thing about the anterior capsule in children. It is very elastic. It has twice the elasticity and 4 times the tensile strength of elderly adult capsules. So it really is different when you're trying to get used to doing a capsulorhexis. Now, my newer microscope, I have this overlay that I can choose to use, which gives me a guide when I'm doing the capsulorhexis. The key here is that the capsule preloads. You have to pull really hard before it starts to tear, and then you have to more pull toward the center. You see I fold it over for a little bit, but then every time it starts to go too wide, I have to pull back toward the center in order to get this very elastic capsule to stay on track and keep from running out. And this is a skill that requires some practice. You can see how I'm fighting to keep the capsule from becoming wider than I want it to be, and it's just very, very different feel than you're used to with adult anterior capsules. Now, because the capsule is very elastic, when I have a fibrotic capsule or a very white lens, I will often use this Clody radiofrequency diathermy unit. The Clody is a diathermy device. It has a foot pedal on and off switch, and it cuts through a capsule in an excellent way. It's something I really like to use, especially in trauma cases. Now, Dr. Antebi was kind enough to invite me, and one of the things that she wanted me to cover was lens subluxation. And I'll show you in a minute my typical Marfan syndrome ectopia lentis surgery. But first, I wanted to show you, this is a case from just a couple of weeks ago. And it is a case where I had about 4 clock hours of absent zonules just developmentally, without a progressive disease like Marfan syndrome. And so here I will utilize the capsular bag. I'm doing, again, a Clody radiofrequency capsulorhexis to try and reduce the tension and the pulling on this fairly loose lens. You can tell when I'm aspirating the lens with bimanual IA. And again, in pediatrics, we don't use phaco. There's no need for phaco energy. So I'm aspirating the lens, and now you can see how much capsule has no zonular support. But the rest of the lens is pretty stable, and we're not dealing with a progressive disease. So in this case, I did retain the capsule and place a capsule tension ring, and then place a lens within the capsular bag. Now, had this case had extensive phacodenesis or a sign of progressive ectopia lentis, then I would not be doing a capsule sparing technique. And most of the Marfan's cases, I don't. Here, as you would do in an adult, I'm placing a capsule tension ring. This child is 3 years old and has and slowly developed this completely white cataract. And once the capsule tension ring is in place, then I'm happy that there's enough centration that I did not feel like I needed to do any sutures, and so far that's proved to be adequate. Now I'm placing the lens in the capsular bag, and I did a pars plana posterior capsule opening in this child. Here's more typical. This is an 8-year-old bilateral ectopia lentis from Marfan syndrome. These lenses very loose, progressive. Some of them are much worse than this. And what I tend to do is I make 2 small openings in the capsular bag. I place the irrigation and the aspirator inside the capsular bag, and I do an inside the capsular bag aspiration of all of the lens material. That stabilizes the bag. Then I turn the cutter on and I remove the entire loose capsular bag. Here I have used Myocol to strengthen the pupil, and I'm using an Artisan iris claw lens. We just reported on our series of iris claw lenses. I now have 81 of these implanted in children. And compared to other techniques, I find this to be my favorite. In the Q&A, we can talk about other things. Angle supported anterior chamber lenses, I don't recommend in children. We are actually reporting on long-term follow-up of our angle supported anterior chamber lenses. That's going to be reported on at the APOS meeting, which is coming up in a month or two. The other technique that I use when the child does not qualify for an Artisan lens is a intrascleral fixating technique called the Yamani technique. This has recently been reported in children. It's had a long enough track record in adults, and now in just this past month, Surendra Basti and his co-authors in Chicago have reported a nice series with decent follow-up where the Yamani intrascleral fixation technique with a flanged end to the 3-piece implant. So that may be acceptable for children, but my preferred technique is to remove the entire capsular bag and use the Artisan aphakia lens. And I have now 6 years of follow-up in the first group that I've done, and I've been very pleased with it. And as I said, I now have 81 to date. Now, certainly in older children, that third group, if you remember that initial diagram, I will often leave the posterior capsule intact and then do a YAG laser capsulotomy. But often, though, I remove the posterior capsule, even in these older children, and this is typical of that. This is a primary manual posterior capsulorhexis without a vitrectomy. Just push the vitreous face back with some OVD, and that works very well with or without optic capture. If you do leave the posterior capsule intact in children that you think are old enough to sit for a YAG laser, this word of caution, I mean, if you get posterior capsule opacification, apply the YAG laser early in the process. Cases like this where the PCO gets so thick that you really can't get through it with a laser. These cases get sent to me and I do a pars plana. I go to the OR and I remove this posterior capsule and this built up material through the pars plana. It's very quick and easy, but it's what happens if you wait too long before doing the YAG laser. And sometimes even a successful YAG laser in an older child will leave capsular debris in the visual axis. In adults, any capsule material falls out of the visual axis. But in children, because their vitreous is much more formed, it may stay in the visual axis. And this, again, I had to clean this up through the pars plana, even though it was a successful YAG laser. And so that's why, I mean, when I can, I'm often more comfortable doing a primary posterior capsule removal in children, even children that are a bit older. I mean, that's become my bias as the years have gone. Now, a word about choosing an intraocular lens. In adults, the cataract procedure is more than just removing an opaque lens. I mean, it is a refractive procedure, and it corrects for myopia and hyperopia and astigmatism. Not so much in children. What happens in children is we are removing this all-important offset. So the lens power that changes to offset axial growth, that is thrown off when we have to remove the lens. So of course, what happens is you get myopic shift and you also create permanent presbyopia where it was not there before. And so those are downsides. And that's why we don't do pediatric cataract surgery unless it's necessary. The blur from the cataract has to be severe enough to justify derailing the emmetropization process and creating permanent presbyopia in the eye. Now, we know that the majority of growth is early in life, and then it slows down dramatically. And you might think that there's no growth in the second decade after age 10. But there is. This is a chart of patients we followed with axial length monitoring, and you can see that there is substantial growth in the second decade, but it is all over the place, very difficult to predict. Now, when you're placing an intraocular lens, if you want to avoid high myopia later, if you want to reduce the rate of having to exchange the intraocular lens when the child's fully grown, this is a typical chart that you might find that shows you the amount of hyperopia that you need to leave. The problem is that not all 3-year-olds, let's say, are the same. Not all 1-year-olds are the same. And so with this in mind, we created a formula. Now, I really draw your attention to this article. I think it's worth pulling and studying. It was in the AJO in 2019, and I'm using it more and more in the operating room. And what this does is it gives you a formula to predict in each individual patient at the time of implantation. You can predict what the axial length will be in this particular child at age 20. Then you can put that axial length into the formula. I use the Holiday 1 formula. All the formulas are approximately the same. We run the Barrett and we run the Holiday. But you can take now this predicted axial length instead of the actual axial length. You put the predicted axial length along with the K readings at the time of surgery, and you can then calculate what implant it would take to yield emetropia at age 20. Now, you might choose to allow for -1 or -2 at age 20, but I think it individualizes the choice of an implant, and so far it's proven to be accurate. Now, despite all of that, all of us that do pediatric cataracts, we have patients who are in their teenage years, sometimes even younger than that, but certainly kids who have had the implant in for some period of time, where they've developed high myopia, and more we're having to do these intraocular lens exchanges. I can tell you that sometimes they're easy and sometimes they're more difficult. The goal is to, as atraumatically as possible, get the haptic out of the capsular bag and get the optic and the haptic rotated into the anterior chamber. Now, we're fortunate in that children develop a lot of fibrosis of their anterior and posterior capsule edges, and that helps us because the residual capsule is often pretty rugged. Not always, but it is often that way. In this case, you see that I am rotating the lens out of the capsular bag, and then I like to use the Packer-Chang scissors and grasping forceps. They fit on an MST handle and remove the two halves of the lens. And then in this case, I was able to place the new lens in the capsular bag. Sometimes the best you can do is to put the new lens in the ciliary sulcus, and that's really okay. Here I'm cutting the lens in half and removing it. Now, these, if you can avoid these by having the child tolerate hyperopic glasses after implant and calculating better, that would be my choice. But it doesn't always happen, and so I'm getting more and more comfortable. I've done so many of these IOL exchanges. I'm getting more comfortable with them, but they can be daunting to do. And you have some other choices. I mean, you could piggyback an ICL over the implant, but most of us are removing the lens and then placing a new one in its place. Now, is there anything else coming down the pike? We've been waiting for years for some of these devices that have been tested. Here's one of them. This is a modular design where the haptics would remain sealed in the capsular bag, and all you would exchange is the optic. This optic pops in and out, and you'd be able to pop it out, put a new one in, change the power that way. Claire Vista initially tested this in adults, and then Alcon now purchased them And we're not sure. We're not sure, at least in the United States, if this will make it to market, but it certainly has an application for children. Now, and one other thing for the future. What about femtosecond? That's an adult technique in pediatrics. We haven't used it because it requires moving the patient to a different room, and usually the laser is not at the same place where we're operating kids. But I am zscheduled to do a few sessions with this portable femtosecond laser made by Zimmer. It rolls in and out of the room. It has an articulated arm that can go into the sterile field and then come out of the sterile field. We are working on having this. This is one article where they did anterior capsule rhexis. We are working to try and predictably do both anterior capsule and posterior capsule openings with more assurance of size and centration. I don't know whether this will be practical, but we're certainly going to try it. And I think these modular portable femtos will be the wave of the future. If you use, now I don't have access to this in the United States yet. I don't know if you have access to it in Israel, but this is something called a bag in the lens. A technique like this is an implant that's really well suited for kids, but you have to be able to do a very precise anterior and posterior capsulorhexis. And the femtosecond laser would allow us to do that if we have access to that technology. One last thing, I really like anything that can be placed in the eye without having to rely on parental compliance. Some of these sustained release, there are some sustained release steroids that go in the anterior chamber. The one I showed earlier goes in the lacrimal puncta. They release medicine around the clock, even when the child's asleep. We now have, the FDA has directed us to study the Dextenza in a randomized clinical trial, and that is underway at present. The most important intracameral medicine is the antibiotic. And I think in children, because we open the posterior capsule often and we're in the vitreous often, that our risk of endophthalmitis may be higher than it is in adults. So I was an early proponent of intracameral antibiotics at pediatric cataract surgery, and I like moxifloxacin. I've always liked moxifloxacin better because there's no dilution, and we've used it successfully. And I was just happy to see, there are lots of articles on intracameral antibiotics, but I was happy to see here in 2020 this article out of Toronto that found that moxifloxacin was just as safe in the pediatric anterior chamber as it is in the subconjunctival space. And it is so much more effective in the eye than in the subconjunctival space. So I was happy to see that. And I'll end there. Special thanks to my wife, Donna, and to my research associate, Rupal Trivedi. I really thank you for inviting me, and I look forward to some questions and answers. Thank you.
Hi, Ed. Thank you. That was amazing. I mean, I was holding on to every word. You managed in quite a short time to really cover a lot of topics, a lot of technical topics as well. There are many of us that are actually pediatric ophthalmology and cataract surgeons who are here. One of the questions that come up a lot in Israel is, who is supposed to do these cataract surgeries? There is always the adult surgeons who feel, rightly so, that they do a lot of cataracts. Why should they not be the ones doing at least the technical part of a pediatric cataract? Why do we need all these pediatric ophthalmologists doing cataract surgery? They don't do enough. They don't, and we have this discussion going back and forth. Of course, my take on this is that the pediatric cataract surgeon should be a pediatric ophthalmologist because he does, like you probably put it there as well, see the whole picture, and he is able to follow these children not only intraoperatively but around the surgery and for 10 or 15 years to make sure that they get everything they need on time. But I would like to get your intake on this because I'm sure you hear it a lot as well.
Right. And I think there's no one correct answer. I mean, I think it depends on the region. It depends on volume. I'm certainly biased in that I think pediatric ophthalmologists should be comprehensive surgeons. We know the differences between the adult eye and the pediatric eye. The same argument is made with retinopathy prematurity. We teach our fellows that we do the screening, we do the laser, we do the injections. An argument could be made that doing so few lasers and injections that the retina specialist should be doing it. And again, the answer is different depending on where you are. I think that an adult cataract surgeon who becomes proficient at kids, who's willing to take the extra time to put up with the general anesthesia and slow turnover, if they're really dedicated to it, they could do a great job. But a pediatric ophthalmologist can too, even with a relatively low volume, by using certain rules and applying pediatric techniques and making sure that they review the videos and all that. I mean, we teach our fellows to do glaucoma surgery and to do ptosis surgery and to do nasolacrimal tubes. I mean, all of those could be handed off. You can make an argument for handing those off to the adult specialist. So I'm a firm believer that in the comprehensive pediatric ophthalmologist, I don't do retinal detachment surgery and I don't do corneal transplants, but I try to stay up on everything else.
Yes, thank you. We had some questions regarding the parameters that you use with the vitrector, for the vitrector axis, for the aspiration, for the anterior vitrectomy. I don't know what vitrector you use.
Yeah, I'm using the Constellation, which is an Alcon machine. I used to think that the cutting rate should be lowered when you're cutting capsule and raised higher when you're cutting vitreous, but I don't think that's necessary. I mean, for a long time now, I just place the machine on its highest cut rate, and the higher the cut rate, the safer it is, less vitreoretinal traction. And you don't need to turn it down for capsule. It cuts the anterior capsule and the posterior capsule just fine that way. My vitrector is set on 7,500 cuts a minute, and it's set that way all the time, no matter what I'm cutting. The aspiration, I like a Venturi pump machine where I can control fluid. I usually have the fluid up pretty high at 50 most of the time, at 30 when I'm doing pars plana. And the aspiration I set fairly high because I like to control it with the foot pedal. And but you use just enough. Aspiration rates are pretty high, but you don't want a lot of chamber bounce. So you want to come off the foot pedal if you're getting a lot of leak around your instruments and if you're getting a lot of shallowing of the chamber. I urge people to make incisions that are a tight fit around whatever instruments they're going to use, whether it's coaxial or bimanual. And you could see there, I prefer bimanual, but there's nothing wrong with a coaxial approach either.
Okay. We have a question from one of our uveitis specialists. She sees a lot of pediatric uveitis, Dr. Radhond Amel at Hadassah. And she asks you if you have any special tips regarding uveitic cataract, which is, of course, a different story. And the question that always comes back with whether yes or no to implant an IOL. How do you prepare these children? How do you approach these children?
Well, I work very closely with the rheumatologist, and our pediatric rheumatologists are really good when we've got the anterior chamber clear for a few months, and in anticipation of surgery, the rheumatologist will maximize the systemic medicines. I try to stay away from oral steroids if I can. With the help of rheumatology, we don't have to go there as often. When I put an intraocular lens in a uveitic cataract patient, I use 4 milligrams of triessence. So intraocular preservative-free triamcinolone, I found, is an excellent medicine for uveitic cataracts. The JRA patients are a subset of uveitic patients where the intraocular lens implantation often does poorly. So I'm much more cautious with JRA, but I'm pretty aggressive with implanting other types of uveitis because they tend to do pretty well if you control the inflammation. And I don't, I think using oral steroids before and after surgery, if you have to, with triamcinolone and other rheumatological drugs, I try not to.
Okay. How do you manage children with not so good capsular support, like after trauma, or if you can't use the capsule the way you have done in your beautiful videos here, what would be your choice of IOL? How would you manage these?
Yeah, I think that you can often support a sulcus lens with less capsule than you might think. I mean, in a trauma situation, the part that's absent is absent, but the part that's present usually is stable and not progressive. So I carefully look at what support I have, and sometimes I can feel very comfortable with a lens, then others might not feel so comfortable. If I just can't preserve any capsule, my tendency lately has been to leave the eye aphakic and come back secondarily with an artisan if they have enough iris. I used to do more sutured IOLs. I've had some of the Prolene sutures break after many years, and I've not done any of the 4-point fixation Gore-Tex ones, but I know that our adult colleagues are doing less and less of those and more of the Yamane technique. Mm-hmm. I was very cautious with that technique and melting the end of the haptic, and we have the special Zeiss lens, and we've got the special 30 gauge needle that is thin walled. So, we've got all the tools. I have one of those on the books for the next couple of weeks where there just isn't enough iris support because of trauma to support an iris claw, and so I'm going to do the Yamane, but I still feel inexperienced at it, and I rely on, I'm fortunate I'm in a department that has cornea specialists and cataract specialists and people that can help me through the learning curve, and I've never been shy about learning from a fellow or learning from an adult cataract doctor or glaucoma doctor or anybody else. So I think that I'm moving away from sutured and a little more toward the intrascleral techniques, and we'll see how that works. The sclera is soft in kids, and it's still growing. And there's also nothing wrong with leaving a child aphakic and putting them in a contact lens and wait and see what happens down the line, you know, and have, you know, have people to operate with you.
Yes. There is a specific question regarding the Carle-Veil lens. I don't know that myself. Carle-Veil lens. Have you heard about that?
I don't know
Okay.
that
I
lens.
think it's from one of our Dutch lectures. So they asked if you had any experience. Many people actually like the artisan lens, but instead of leaving it in the anterior part, they put it in the posterior part of the iris.
Right. Yeah, it's one of the quirky things with us is the artisan lens is not on the U.S. market.
Yes.
So we gained access through this mechanism with our FDA called compassionate use. And so we have a compassionate use protocol that is relatively benign. We have to send them records for 5 years. But in that protocol, we have age 2 to 21, but they will not let us put it on the back of the iris. Now, we weren't in there at the very beginning enough to convince them to be a little looser with the way they wrote that protocol. But until it gets a full FDA support, we're just not allowed to do that. And I could argue that the anterior placement is much easier to correct when with some mild trauma, one of the haptics deinclavates. And we're collecting every year, we're getting endothelial cell counts. So we're collecting with all the people in the US that are doing it under this protocol, and we've not found any corneal decompensation. So the main reason to put it on the back of the iris is to get it away from the cornea. The downside is it's much harder to repair it if it comes loose. And we've all had a few of them come loose with minor trauma, and it's so easy to repair them when I can see it in front of the iris.
Yes, I've seen a few of our artisan lenses come back after the child is getting trauma for some. I mean, that children are children, and they are children, so they get trauma, and then it dislodges, and you have to go in and put it back and enclavate it again. So it's a great lens, but it's perhaps not the best for kids who are very active. The lens that we were not aware of is a sclera fixated lens without sutures. Maybe it's used in Europe, and I don't know if you have this in the United States.
Yeah, I mean, that's the main advantage of the Yamani technique is there's no sutures involved, and it's much simpler because you externalize the haptics. And then you create a little mushroom cap on the end of the haptic so it doesn't go back in. And that just seemed it's a Japanese invention, but it's so innovative. And I worried a little bit about the soft sclera in children. I've been following people around the world who are doing it in kids to see if that little mushroom works its way into that soft sclera. Or if you get more tilt or something like that. But I'm beginning to get more confident that there's enough pediatric experience around the world that I haven't seen any real disasters. But I'm slow sometimes to adopt something that I think I have an alternative for. We have to protect the kids. My colleague Rick Saunders always says, use a new technique in a hurry while it still works, because you want to wait and let the adults get the bugs out of it first before we apply it to our kids.
And the kids live many years, so we are to see many of their complications later on, like with the anterior chamber IOLs that were hardly used anymore in children now because of what they do to the cornea. Yes.
And we found that after some years, there's enough growth of the eye that I've had some that were stable for 3 or 4 years and then started rotating. Mm-hmm. And as they rotate, then they oval the pupil. And I've even seen some pediatric CME from that. So sizing is such a big problem. That's at least the artisan is one size fits all. And if the eye changes its size after you implant the lens, at least it's not a problem.
Yes. Have you done piggyback for IOLs that become really myopic later on, the children? Or do you just replace them like you showed us here? Because it looked very nice on the movie, but I know that it's difficult.
Yeah, I usually replace them. I have a few that I'm following where I put in a regular minus IOL. I mean, just, you know, a regular posterior chamber IOL and minus powers. What I haven't done is piggyback an ICL, but we've been talking about that with our fellows and with our cornea specialists, and I think that the problem is the ICL in the US is a cash pay lens. I think it has good promise to be able to slide in on top of, you know, just do a PI or two and then slide it in on top of the bag fixated lens, and we will try that. The problem is that we can't get the families to pay for it, and at least if I piggyback a standard implant, usually insurance will pay for it, but they won't pay for the ICL because it's already been designated as a cosmetic, you know, phakic IOL.
Ed, I would love to keep chatting with you all night, but we have other lectures coming up, and I just want to thank you really from the bottom of my heart and for everyone here. We were up to 115 and some more people listening to you. It was amazing. We will have you come back, I hope, in person. And there are so many other subjects, subjects that we could actually be discussing, but we have to move on. And thank you so much. Enjoy your clinic of 25 kids.
I will enjoy it. And if there's anything left in the chat box that you want to just email it to me, I can always provide a written response. All right.
Thank you.
Thank you.
Thank you, Ed. Bye.